Okay,
Do it. Yeah, it's done.
so we started recording. Let's start. Can you see the?
Oh wow, yeah, wicked.
Can you see it, guys?
Yeah.
Perfect. So this is the Primal Therapy CPD. For those of you who don't know me, I think Jernan already knows, Karan already knows. Albi, you don't know me. I'm a physical therapist in Lebanon. I have a master's degree in sports rehab and all of the sports, actually. I can rehab all of the sports. So basically that's it. I did a CPD, a lot of CPDs in dry needling. I am a dry needling practitioner, basic level and advanced level. I have a certificate in sports management as well, on court and off court. Basically that's it. So let's start with the ACL CPD now. So we're gonna start talking about the general facts about the ACL, the anterior cruciate ligament tears. Normally the ACL can withstand approximately 400 pounds, which is approximately 181 kilograms of force, which is huge. It is a common injury, particularly in sports. 3% of all athletic injuries are ACL injuries. And the player may hear a pop sound and feel the knee give away when he tears his ACL, which is normal. Some people don't actually, rarely people don't hear a pop, but mostly I hear from my patients and from the players telling me that they heard a pop or they felt a sensation of their knee giving away when they tore their ACL. So we have different types of ACL tears. We have the partial tear, as you can see in this image. We have the avulsion tear. We have the complete tear. The difference between the avulsion and the complete tear is that the complete tear would be in the middle of the body of the ligament. The avulsion tear would be directly from the bone, from the tibia or from the femur. It's torn from the bone immediately. So the causes of the ACL injuries, mainly the cutting, which means the rotation while cutting the player or the patient while cutting, he tears his ACL, or by hyperextension. We all know that when we extend the knee, the ACL is at its full length. That's why the hyperextension can hurt and can tear the ACL. So a straight knee landing in hyperextension, or when the knee is extended, the ACL is at its maximal length, putting it at an increased risk of tearing. The external factors for ACL tear are the amount of lower body strength, that's for sure, and the footwear and the surface interaction that the player is playing at. Sometimes we have with the ACL, we call the unhappy triad. The injury, this is the most notorious injury. I don't like treating such an injury because it's huge, which is the ACL and the MCL and the medial menisci. The medial meniscus are torn at the same time with in one injury. That's called the unhappy triad. In order to find out, to diagnose an ACL, we have two main tests that we use: the Lachman test and the anterior drawer test. Normal knees have 2 to 4 millimeter of anterior translation and a solid endpoint. So which means when we are testing for an ACL tear, a normal knee should have a translation of 2 to 4 millimeters and a solid endpoint. When we push in the anterior drawer test, for example, we feel that there is a sensation of solidity in the end. While when the ACL is torn, we can't feel this solid endpoint. So an ACL injury will have increased translation and a soft endpoint in the end. Now, the ACL injuries in female athletes. Why are women more susceptible to ACL injuries than men? A study on an NCAA players has shown that ACL tears are 4 times more common in women than men basketball players. Also 3 times more in gymnasts in women more than men. 2.4 times more in women in soccer. And they have found also higher rates among women in team handball, volleyball, and alpine skiing. So why do women are more susceptible? Why are women are more susceptible to ACL tears than men? And that's for many factors. One of those factors are the weaker hamstrings, a ratio of 10 of quadriceps to 7 of hamstrings, the hormones, the estrogen in women, which reduces collagen strength, and the hormone relaxin. This hormone relaxin makes the ligaments and the tissues more, how do we say it? More lax, if you want. They increase the laxity in the laxicity in the tissues, which makes it for women more prone to be to have an ACL tear than men. Now we're gonna start talking about the rehab. So the ACL rehab has undergone a lot of changes during the past decade. A lot of research has come up with the has increased the ACL rehab, or has changed the ACL rehab and related to the biomechanics of the injured and the operated knee, which have led to a movement away from the techniques of the early 1980s, which were characterized by post-operative casting, delayed weight bearing, and limitation of range of motion, to the current early rehabilitation program with immediate training of range of motion and weight-bearing exercise. So in the 1980s, they used to put a cast, do not walk on it, put crutches on for 3 weeks or 1 month, don't walk on your injured knee, and they didn't used to work on the range of motion. Now, in these days, the research has shown that walking early and early weight bearing and early range of motion exercises are pretty good for the knee after an ACL surgery. So the ACL rehab is both for the conservative and the surgical options. I'm gonna list the week one, all of the characteristics of the ACL rehab, and those characteristics are the same for the conservative and the surgical options, whether the patient decides to go for the conservative treatment or for the surgical treatment. The physio is the same. So for the conservative treatment of an ACL injury, it could be the best choice for the sedentary patients. Normally we use it and we advise older people, elderly people, and sedentary people to go for the conservative treatment, since they have no use of all of the ACL characteristics. Indeed, patient age and sportive activities and foremost subject of instability symptoms in daily life activities should be considered when deciding for or against ACL reconstructions, the surgery. In those cases, a physiotherapy program of complete regain of range of motion, a comprehensive program of reinforcement and restoring of proprioception, and a normal gait pattern training could be the best rehabilitation protocol for these kind of people, for sedentary and elderly people. However, if we find that symptomatic instability of the knee is not reduced after the rehab protocol, nor after the adjustment of the activity, the ACL reconstruction then is recommended. This might prevent multiple interventions because of further meniscal and cartilage damage. So what we fear when we go for the conservative treatment is the osteoarthritis, the risk of osteoarthritis for those people who chose to have the conservative treatment of rather than the surgical treatment. So mainly when we go for the surgical treatment, it's also for the quick return to sport, also and also to prevent the future osteoarthritis in the knee. So therefore the injuries in the ACL rarely occur in isolation. The presence and extent of other injuries may affect the way in which the ACL injury is managed. Indeed, the mechanism of the injury can damage also the MCL or the meniscus, which we talked about in the unhappy triad. Other associated injuries could be microfractures or bone contusions, both with or without chondral injuries. So we frequently see on the MRI that the bone have contusions because when the ACL ruptures, the two bones, the femur and the tibia, they hit one against each other, and we see a lot of bone contusions, whether in the tibia or and also chondral injuries in the femur or in the tibia. In those cases, the ACL rehab program must not be standardized, and they should consider the comorbidity of the patient. Now we're gonna go deeply into the ACL, the goals of the rehab and the ACL injured knee. Our main goals are to gain full range of motion, first of all, to repair the muscle strength and the proprioception, to gain good functional stability, to reach the best possible functional level in walking, running, and jumping, to decrease the risk of re-injury, and then to return to sport. There's a lot of research talking about 2 years post-op after an ACL tear. They found that the contralateral, the same patient has a higher risk of risking his contralateral knee ACL or re-rupturing his ACL, his reconstructed ACL. So this research has given advices that we should keep on rehabbing the ACL, the injured knee, for as long as we can before the return to sport. And even after the return to sport, we should keep on following up with our patient in order to prevent his risk of re-injury and lower his risk of re-injury. Now, the physiotherapy intervention could be divided in a lot of phases, but mainly those are the main phases: the acute stage, the pre-surgical stage or the conservative treatment stage, the after-surgery stage, and the return to sports stage. Now I'm going to talk about each stage alone. First of all, the acute stage. After an ACL injury, which has already happened, and regardless of whether surgery will take place or not, physiotherapy management focuses on regaining range of movement, strength, proprioception, and stability, the main pillars of the ACL rehab. In the acute stage, we use the PRICE or the peace and love protocols, which should be used in order to reduce swelling and pain, to attempt full range of motion, and to decrease joint effusion. An adequate anti-inflammatory medication are used to help control pain and swelling in this stage. The indication of use of crutches and eventually a knee immobilizer could be appropriate in some patients. However, extended use of the knee immobilizer should be limited to avoid quadriceps atrophy. So what I suggest for my patients is that they use the immobilizer and the crutches. The crutches they can use as long as they want. I want them to feel comfortable when they remove the crutches. When they decide when to remove the crutches, of course, I can give them an advice. I can help them out with the decision of when to remove the crutches. But the knee immobilizer, I don't like it a lot. I like to use it for tops 1 week, and that's it, post-op. Because I hate it. I hate the fact that it helps with the quadriceps atrophy, and that's what we really don't want when we are rehabbing an ACL tear. It is also demonstrated that neuromuscular electrical stimulation combined with the exercise is more effective in improving the quadriceps strength than exercise alone. So what I do basically is that I use the neuromuscular electrical stimulation, the electrotherapy basically, and I combine it with exercises. So I ask him, I put on the electrotherapy on him, and I tell him to do an exercise while the electrotherapy is working. So for example, we can use the strengthening current. While using the strengthening current, I ask him, when the current comes on, you do this exercise. For example, you flex your knee, or you do a straight leg raise. And that's how we combine the electrotherapy with the exercise. The neuromuscular inhibition of the quadriceps caused by the intra-articular effusion may have a negative effect on the strengthening. So I find also, and for the people who have worked on ACL injuries, we find that strengthening the quadriceps at first, the first 2 weeks is a bit slow because there is a lot of joint effusion and there is a lot of inflammation in that knee, which inhibits the quadriceps from strengthening and from working properly. In any case, case, exercises should encourage range of motion, initial strengthening of the quadriceps and hamstrings, and eventually proprioception. So still, our focus is not at first, the first 2 weeks is not strengthening the quadriceps alone as much as we prefer focusing on regaining the full range of motion. And we're going to talk about what movements that we want regaining the range of motion in order to perfect this ACL rehab. In fact, the strength and proprioceptive alterations occur in both the injured and the uninjured limb. We shouldn't forget about also rehabbing the uninjured limb. The contralateral knee. Also, I find that there is a higher risk for tendonitis in the other knee since since this patient is only relying on his good knee and not his bad knee at first, for the first month at least. So we should tell him not to do a lot of strenuous movements or strenuous exercises on his other knee in order not to go into that field of tendonitis and tendon issues or even articular issues. He should be strengthening the other knee as well in order to prevent these kind of injuries. To assess preoperative optimization, the following guidelines are recommended in the acute and early subacute stages post-injury. So in the acute stage also, the full extension, first of all, we want to regain the range of motion of the full extension of the knee. As you can see in the ACL, in the knee, once it's operated on, the full extension is not there. So what we want is regaining full extension at first before the flexion, which is more important the first 2 weeks. And then the flexion comes by doing the exercises, by strengthening the hamstring and the quadriceps as well. So the full extension is obtained by doing passive knee extension. The physiotherapist can provide the passive knee extension both with manual therapy or teaching exercises, which they add leverage to gently force the extension in the injured knee. Also, we can teach the patient, the injured person, how to do a patellar self-mobilization, which is very important the first 2 weeks because the patella needs mobilization in order to function properly, in order for the knee joint to function properly. We can do the heel props, we can do the prone hang exercise, and we can do the static quads or the single leg raise. We can teach this to our patient. Then we focus on the flexion of the knee by doing the passive knee bend, which the physiotherapist can provide the knee flexion both with manual therapy or by teaching him exercises. The knee flexion in prone, which is the gentle kicking exercise, as much as he can, as much as he's comfortable with, we can ask him to gently flex his knee, or we can help him out by pushing a little bit with his knee. Pushing passively his knee and helping him out if he doesn't have a lot of strength in his hamstring. We can do the wall slides. We can do the heel slides. The wall slides, he's basically on his back against the wall, perpendicular to a wall. His knee are on the wall. He tries to slide his ankles down by flexing his knees, which helps the flexion of the knee. The heel slides on his back on the table, on the treatment table. He slides his heels back to his glutes, which helps him out a little bit with the flexion. But I prefer the knee flexion in the prone position because it's very specific to the knee. But we can do it not the first week, maybe, because it's a bit strenuous on the knee. So I prefer doing the heel slides at first. I don't like the heel slides because the hip gets into act in this kind of in this kind of exercise, I prefer focusing mainly on the knee joint. Also, with the knee flexion and extension and sitting, we can do the ankle dorsiflexion, plantar flexion, and the circumduction. The gluteus medius work in the side lying position. The gluteal exercises in prone position. We shouldn't forget about treating the supraarticular and the infraarticular joints, because we cannot ignore the effect of the hip and the ankle on the knee joint. So we should also work on the ankle and the knee and the hip joint, as well as the knee joint. We can do the weight transfers in the standing position, forwards, backwards, and then side to side. And now we reach the before the surgical state. In the stage of the before surgery, the highest incidence of knee stiffness occurs if ACL surgery is performed when the knee is swollen, painful, and has a limited range of motion. So I found that physiotherapy, and also research has found that physiotherapy before surgery is very important to our patients, and it's very important on the rehab post-op. For example, I have a lot of patients who didn't do the rehab before the surgery, which complicated a little bit the rehab after surgery. While the people who did the rehab before surgery, sometimes people tend to not do it because they're lazy, or they don't want to, they're maybe scared to do the rehab before the surgery. They think that they have this idea that we're gonna mess it up more if we do rehab before the surgery, so they tend not to do it. But actually what they should do is do this rehab before surgery, which is very important, because it decreases the inflammation in the knee. It decreases the joint effusion, and which helps the surgeon in his job by having a good surgery, and which helps eventually the rehab post-op. So before surgery, our program focuses mainly on the RICE and electrotherapy, which can be applied for several weeks ahead of the surgery in order to obtain full range of motion and to decrease joint effusion. The patient should also have a normal gait pattern. We should work on his gait pattern. Because of that, it is useful to analyze the motion of the leg, both in the swing phase of walking and in the one leg standing phase. Thus, this will help the patient regain faster motion and stronger, and become stronger after surgery. Also, we should obtain a full range of motion and extension, and keep improving the range of motion and flexion with minimal swelling. So we notice also that before surgery, after his ACL tear, we find that he has a limited motion in his flexion and extension. We should work on the extension first, and then work as much as we can on the flexion before the surgery. As much as we can help him before the surgery, this will help us after the surgery. Can you hear me, guys? It's telling me that my internet connection is unstable.
Yeah, all good.
Okay. So also we should develop muscle. Excuse me, adrenaline? Okay. So we should develop also muscle strength. Once the 110 degrees of flexion has been achieved, you may begin to work on muscular strength. For example, we can do these exercises like swimming. We should avoid the breaststroke. The low impact exercises machines such as an elliptical, cross trainer, stationary bicycle, or a treadmill. The leg press machine, the leg curl machine, the leg extension machine, the weight bearing exercises such as squats, lunges, step ups. In this phase, of course, no cutting, no hyperextension movement in the knee. This will put this person at risk again. And we don't want to sensitize this region before surgery. We just want it to stay calm as much as we can, in order to help the patient even more. We should improve the proprioception. We can do one leg standing exercises, adding balance also, or we can make it harder, adding cushions or cues for the arms, for example, throwing a ball and letting him catch it. For example, reaching a target in his other leg. We can do also exercises in different planes, the frontal, the sagittal plane. We can do also preparation for the controlled jumps. We can prepare him for the controlled jumps. Also, we should mentally prepare this person, which I find very important. We should mentally and psychologically prepare this patient for the surgery and for what to expect in the future after the surgery. We don't want him to be down. The mental health of the patient in an ACL rehab, rehab like the ACL injury, it takes a lot of time. Now the research has shown that that people shouldn't go back to sport before at least 9 months. So 9 months of not practicing the sport, of rehabbing all the time, it's huge. What I do basically is I rehab him for 6 or 7 months if he needs me, and then I refer him to a trainer, a fitness trainer, which works with him for the next 2 months or 3 months, in improving his endurance and improving his strength and improving his coordination, and improving his proprioception as well, and doing functional exercises related to his sport, which will help him out a lot. But we should prepare this patient in order to be mentally prepared for what comes next. This is very important, because people tend to during the rehab, they tend to go up, they have their ups and downs, and during their downs, I've had this issue with a lot of people, because they tend to not come to the rehab anymore, though they know that they need it, but they are maybe they become a little bit depressed from the situation, especially at first, the first 2 months, because they don't have this control over their knee. They still didn't walk normally or properly. So and they become as well, they need to get back to sport as much as they can, and as fast as they can. And this, I find, we should prepare them for this and tell them that you need to be patient, you need to trust the process, and you need to listen to what I'm telling you in order to reach our goal and to reach it with the minimal risk. Now, after the surgery, after the ACL reconstruction has undergone considerable changes over the past decade, the various tissues and grafts have been used to anatomically reconstruct the torn ACL. Now, the most commonly used are autografts, which are patellar, bone, and hamstring, and sometimes allografts. They are taken from cadavers. I prefer doing autografts, which is removing the patellar tendon or the hamstring tendon and reconstructing it into an ACL. But sometimes if we don't have the autografts, we can go for the allografts, which are taken from cadavers. But I don't like this one, because sometimes the body rejects the allografts, and I've seen it a lot. That's why I prefer the autograft instead of the allograft. The process of ligamentization of the grafts needs precautions in terms of loading and physical requests. So it seems you know that even if the body doesn't reject this new ACL reconstructed, we have a process of ligamentization, which means the body is going to try. Now we're putting a tendon instead of ligament as an ACL. The knee and the brain are gonna try to ligamentize, let's say, ligamentize this tendon into a ligament. This process, it takes a lot of time, and more than the rehab time. So, but that's why we're asking for at least 9 months, and we can go up to 1 year before returning to sport, in order for this ligamentization process to be at least a little bit, we can be over with this ligamentization process. So it seems indicated that the remodeling of the new ACL is a process that continues for 9 years or more, which is huge. Furthermore, it seems to be a process of adaptation rather than full restoration. The body needs to adapt to the new ACL and not restore the full ACL. We should consider pain, swelling, muscular contracture, limitation in the range of motion, and abnormal gait patterns as indicators for having a good outcome. In the after surgery stage, 3 factors are very important, which are the early terminal knee extension equal to the contralateral side. We always compare to our good side. the first by doing the extension, by reaching the full knee extension. Early weight bearing, we should as much as we can. For example, here in Lebanon, after they do the surgery, the next day they start walking. Even the same day they make them walk. The physio in the hospital, they go up to the rooms and they make them walk, because early weight bearing is very important for the knee. Closed and open kinetic chain strengthening exercises. Early knee extension establishes the foundations for the entire rehabilitation program. That's why I emphasize on working on reaching the full knee extension at first. The incidence of the knee flexion contracture with associated quadriceps weakness and extensor mechanism dysfunction following ACL reconstruction has significantly decreased with accelerated knee extension immediately after surgery. So we should also consider this while rehabbing. And according with the ACL rehab guidelines, a good physiotherapy program is depending by achieving goals week by week. So we're going to work through it week by week. So the first week and the second week also, what we do is regular icing and elevation to reduce swelling. The goal in this week, in these 2 weeks actually, is to reach the full extension and 70 degrees of flexion by the end of the first week. We can use, the patient can use a knee brace and crutches according with the surgeon and only if needed. I don't like using a knee brace, but only if he needs to use this knee brace, we can do it. In fact, wearing a knee brace has no additional, research has found that there is no additional treatment value that this brace can give us after an ACL reconstruction. So why use it? Actually, it gives us a disadvantage by helping with the quadriceps atrophy, which we don't want. So the use of the knee brace is progressively reduced by authors, which means post-operative rehabilitative bracing, either in extension or with the hinges open for range of motion, does not offer significant advantages over no bracing. So no bracing is better than bracing for me. We can do the multi-directional mobilizations of the patella that should be included for at least 8 weeks. There is a lot of adhesions that we find post-op, especially in the patella. That's why we shouldn't neglect the patellar mobilizations upwards, downwards, side to side. Those are very important. They help out a lot with the knee range of motion and extension or flexion. Other mobilization exercises in the first 4 weeks are passive extension of the knee, no hyperextension because it could hurt the reconstructed ACL, and passive and active mobilization towards flexion. We can start with the strengthening exercises for the calf muscle, the hamstring, and the quadriceps. Especially, we should focus on the vastus medialis and the quadriceps, and these can be performed supine in a supine or prone position. We can work on the isometric quadriceps exercises, which are very safe in the first 2 weeks. The early weight bearing appears beneficial, and it can decrease the patellofemoral pain. The early motion is safe, and it will help avoid problems with the later arthrofibrosis. So that's why I ask of my patients, and I ask of the physios and of the trainers that I teach. I tell them motion is lotion. So early motion is very good for the knee. It fights adhesions, it fights arthrofibrosis, and it helps with the range of motion, and it helps with the remodeling of this reconstructed ACL. Now, the week 3 and 4. And at this stage, at these weeks, I prefer, there is no evidence that icing and elevation is useful after the week 1, or we can go up to week 2. But the first goal in these week 3 and 4 is maintaining full extension of the knee, because you can lose it. You can lose this extension even if you reach the maximum comparing to the contralateral knee. Even if you reach the extension, the full extension, you can lose it later on while working on the flexion. It happened a lot of times to me. I found out later. I found out during my practice that I'm losing the extension. So I reworked on the knee extension again, because when we work on the knee flexion, we tend to ignore working on the knee extension, which shouldn't be done. So we should watch out for this knee extension loss while working on the flexion mobility. The first goal is maintaining. That's why we should maintain the full extension and increasing the degrees of the flexion week by week. We should try to generally increase the stance phase in an attempt to walk with one crutch. In these weeks, I start teaching the patient that it's now time to remove the crutches. We're not going to remove them both at the same time. We're going to remove one, and I put the second one on his contralateral side. So when he takes his step, let's say, for example, he has an injured right knee. I give him the crutch. I leave him the crutches in the left hand, because when he pushes and when he wants to do in the swing phase, when he's in the swing phase in the gait, and he's moving his right knee towards the front, and he's gonna have to put a weight on it, he can put the left crutches at the same time with the right knee, and he can lean on his crutches instead of leaning totally on his knee. So the strengthening exercises for the calf muscle, the hamstring, and the quadriceps, also the vastus medialis, we should focus on, can be performed sitting using the stationary bicycle or light weights. The progress of the exercise depends on pain, swelling, and the quadriceps control. So if you see that your patient is doing well, we should always challenge him with the exercises that we're giving him, even if he doesn't agree with it. You are the master of the rehab. You dictate how the rehab goes. Also, we shouldn't forget that we should also always listen to the patient. He is the one feeling his knee, so we shouldn't forget what he wants. So we should, at this phase also, we should start eccentric quadriceps training in closed kinetic chain from 3 weeks after the ACL reconstruction is safe, and it contributes to a bigger improvement in quadriceps strength than concentric training. So eccentric is better than concentric at this phase. The quadriceps strength is enhanced with early extension and weight bearing. The combination of early knee extension and early weight bearing and the closed kinetic quadriceps strengthening all allows the patient to progress through the post-operative rehab period at a rather rapid pace without compromising the ligamentous stability. Now at the week 5, we go for passive mobilizations, which should normalize the motility, but the flexion should not yet be thorough. Okay, the tonification of hamstrings and quadriceps can start. Honestly, I found that I sometimes reached the full knee flexion at 3 or 4 weeks post-op. Sometimes it happens because the surgery is very clean. He has done a good rehab before the surgery, and he is very continuous in his rehab post-surgery. This can happen. You can reach the flexion, and I'm sure I've seen on your stories, Karan has showed me a patient of yours with an ACL in the ACL injury, and he has gone through a lot of flexion improvement in the first couple of weeks, which can happen normally. But sometimes, in order to be on the safe side, this protocol is made. But there are always modifications that we can do in this protocol. The exercises should be started on light intensity for the tonification of the hamstrings, 50% at first of maximum force, and then we build on this. We can progressively go to increasing to 60-70% of the maximum force. The closed kinetic chain exercise should be built from rest responsible positions, for example, the leg presses, the steps, or to more congested starting positions, for example, the squat. The progress of the exercise depends also on the patient, the pain, the swelling, and the quadriceps control. Proprioception and coordination exercises can evolve if the general strength is good. So we can go to the proprioception, we can improve the proprioception and the coordination exercises if the general strength is good. This includes balance exercises on boards as well. The week 10 now, the progression of loading is the fundamental from now on. At week 10, which means at 2 months and a half, it's time for loading the knee. Give as much as we can. The proprioception and coordination exercises could be more specific to the individual sports needs of this patient. Forward, backward, and lateral dynamic movements can be included, as well as isokinetic exercises in this stage of the rehab in order to start loading the knee. At 3 months post-op, The patient can move on to functional exercises now, as running and jumping. We can start with a little bit of cutting exercises, a little bit of a little bit of jumping, a little bit of change of direction. As proprioceptive and coordination exercises become heavier, quicker changes in direction are possible now. To stimulate the coordination and the control through afferent and efferent information processing, exercises should be enhanced by variation in invisible input. So we could close his eyes for to work on his proprioception. We can change the surface. For example, we can put him on a trampoline, start jumping on the trampoline, or move or jumping lateral on the trampoline. We can modify the speed of exercise performance. We can ask him to now go to more into explosivity. We can modify the complexity of the task, the resistance of the task, or we can tell him to do this task on a unilateral or on a bilateral position. So at month 4 and 5, the final goal is to maximize the endurance and strength of the knee stabilizers, to optimize the neuromuscular control with plyometric exercises, and to add the sport-specific exercises. At this stage, we are going straight into the sport-specific exercises, plyometric exercises, and everything related to the functional exercises that he needs in his sports. Acceleration and deceleration, variations in running and turning and cutting maneuvers improve arthrokinetic reflexes to prevent new trauma during competition. So these are very important. The acceleration and deceleration exercises are very important. We can give him a drill, a circuit to do jumping, then maybe accelerate, then maybe decelerate, then maybe you can do a jump stop. A lot of variation of exercises are there. We can find them on YouTube. We can find them everywhere in order to give to these patients at month 4 or 5. And the final stage of the rehab is the return to sport. An ACL injury leads to static and functional instability that causes changes in motion patterns and an increased risk of osteoarthrosis. In many cases, an ACL injury results in a premature end to a career in sports. A lot of people have had their career ended by ACL injuries. So we should keep that in mind. ACL injury is not a simple injury. It is a career-ending injury sometimes, but if we treat it right, and if we help the patient, and if we mentally prepare him for this, he can reach it, and he can go through it smoothly. Strength and power deficits after surgery may be a risk factor for future injuries, and they may set athletes up for failure when they try to return to their prior performance levels. Researchers suggest that the surgically repaired leg should perform at least 90% as well as the uninjured leg before you return to sport. So one of the tests that we do before giving him the okay to return to the sport, to the patient, is having, first of all, a strength of 90% of the injured leg compared to the other leg, to the good leg, to the healthy leg. So, and we also can provide him with the 3 hopping tests that can be used as part of a comprehensive physical and functional examination to help ensure not just a speedy but a safe return to sport after the ACL reconstruction. These 3 tests are very sensitive enough to measure side-to-side differences and can be used during more advanced recovery phases after surgery to help ensure that the athlete's exercise program is successful in returning the injured leg at least to the level of the uninjured leg. So these 3 exercises are the single leg hop test, the triple single leg hop test, and the crossover hop test. So I'm going to go through them a little bit fast. The single leg hop test, also we always go with the healthy leg first. We test the healthy leg in a single leg hop test. We are trying to cover as much distance as we can with 1 hop. Then we switch to the injured leg and we see the difference, and we measure the difference of the heel compared to the start. Okay, we measure the difference to the nearest centimeter, and then we compare the difference between the injured leg and the healthy leg, and we see that he reached the 90% of the distance that he reached with the healthy leg. If yes, then he's good to go. Then we go into the triple single leg hop test. Now we are trying to we start also with the healthy leg. We are trying to cover as much distance as we can with each hop. We are doing 3 hops. So he hops 3 times on a single on his single healthy leg, and then we measure the distance. and then he does it with the injured leg, and we compare, and we see the difference between the injured and the healthy leg. And the crossover hop test is he goes in the healthy leg first, he jumps medially and then laterally, three tests, three hops, and we measure the difference also, and he's trying to cover as much distance as he can. And then we go and we do the injured leg, and we compare the injured to the healthy leg. And the athletes who undergo ACL reconstruction should be informed that post-operative participation in level sports increases the 2-year knee re-injury rate more than 4 times. So at a later return to level one of sports, and more symmetrical quadriceps strength prior to return decreases this rate significantly. So as much as we can return to sports as late as we can, it's good for the patient. So if we can make him go back in after a year, that would be great. 9 months, I can take it. I accept 9 months, but I prefer a year. And as strength and conditioning grow, the mechanism of previous injury can guide the last phases of rehab. An ACL reconstruction due to an indirect mechanism of injury could point the focus on coordination exercises between ankle, knee, and hip, or on core stability, or on sport-specific gesture. Thank you. Does anyone have any questions?
Oh, sorry, 1 second.
That was really good.
Thank you.
That was fantastic, man. Thank you, man. That was really, really good, man.
Thank you.
That was really good. No questions from me.
One thing I didn't know was I didn't know you went to mobilize the patella for about 8 weeks. I didn't know that.
Yeah. Very important.
Yeah, I didn't. When I have them, I might do it for maybe 3 weeks. But I didn't know, even less, might even be 2 weeks. And then, but I didn't know 8 weeks is important.
Yeah.
Sorry.
Basically, I work on it personally, I work on it for the first 4 weeks, and then I stop working on it. And if I see that he's having problems within his range of motion, I go first. I check his mobility in the patella, and then I go for the knee extension, and then I check his knee flexion, because the knee extension and knee flexion are gonna be affected if the patella is not working right.
So the patella has a big role in how much the knee can flex and extend as well, then, right?
Sorry?
So the patella has a big role in how the knee will flex and extend.
Of course. When we flex the knee, the patella, when we are flexing the knee, the patella tends to glide, and we are while extending the knee. So it's very important for the gliding to be there in order for the flexion and the extension to be normal. If the patella isn't gliding properly and there are a lot of adhesions in the patella and a restriction in the mobility of the patella, those knee flexion and knee extension are going to be affected.
You know, when you mentioned that you wouldn't do hyperextensions on, but you mentioned to strengthen up the vastus medialis. What exercises do you do to target vastus medialis?
So at first we can go and treat. We can go and do the in the leg extension machine. At the leg extension machine, we all know that the vastus medialis works well in the end range of motion of the knee extension. So, for example, let's say we are extending the knee from 0 to 90 degrees. From 0 to 90, from 0 to 60 degrees, the vastus medialis is working as well as all other quadriceps muscles. But from the 60 to 90 degrees, it's the vastus medialis working alone. And we can put in these last 30 degrees of knee extension, we can work on the vastus medialis, on strengthening the vastus medialis. So if you want to target the vastus medialis specifically, we can put him on a leg extension machine, and we can tell him, for example, you are gonna go from a 60 to 90 degree knee extension, and that's it. We're gonna work specifically on the vastus medialis. That's one exercise that we can work on. Also, we can help him out with the electrotherapy. We can focus on the vastus medialis, putting the electrotherapy on the vastus medialis and strengthening it while doing another exercise, for example, while squatting, or while I don't know, working on his mobility, on his range of motion, flexion or extension.
Would you use blood flow restriction training at any stages?
Yeah, we can use it. And this I didn't mention it in this PDF, but we can use it in the pre-op phase, and we can use it in the post-op phase, especially after the week 1. And we can use it in actually we can use it in all of the phases. It's very important. It's gonna help us out a lot, especially in the pre-op phase and the post-op phase, and if eventually in the end stages of the rehab in the ACL injury.
Okay. Okay. Then my final question is, you know, when you say use the neuromuscular stimulating machines,
Yeah.
could we use the blood flow training instead of that, or they work hand in hand, or would you use one more than the other?
I prefer it depends. Your question has to be specific more in relation to which stage where we are, where in which stage are we.
Early stages.
Early stages, I prefer using the electrostimulation, and we can use the blood flow as well. I'm not saying use this instead of this. We can use both of them, but I prefer the neuromuscular stimulation because the patient at this stage doesn't have a lot of control on his quadriceps, on his muscles. So in order to regain and to have a faster rehab, we can go for the neuromuscular stimulation in this phase, as well as him strengthening his quadriceps, his muscles, to help him out even more. So I find a lot of control issues in the quadriceps in the early stages of the rehab. Why? Because as I talked in this presentation, as I told you, the quadriceps is inhibited by the by the joint effusion, by the inflammation. So this inhibition causes a lack of control on his quadriceps. I can make him regain his control. And if I ask him to contract his quadriceps, he's not going to be able to fully reach his full potential of contraction. So that's why I prefer using the neurostimulation to help him out with contracting his quadriceps, because he doesn't have a lot of control over it now. And as well, we can use the blood flow restriction, the cuffs. We can use them after he regains maybe control over his quadriceps. We can start using the cuffs.
Okay. Okay. I understand. Albie, you got any questions, bro?
No questions from me. It's just it's an eye opener. It's a lot more than just what we thought. There's a lot more to it. We knew a lot anyway, but obviously trying to lock out, let's say, for example, the start is just extension of focusing.
Yeah.
Well, when Keenan mentioned, it's probably better to do the hamstring and the knee flexion stuff in prone rather than supine.
Yeah.
Yeah, I don't mind, but we should watch out for something, guys. Also, if the surgery is not well done, there's a thing that we call the cyclops in the knee. You should watch out for this. If your patient is suffering from a pain after the surgery, located in the middle of his knee, and he says that it's deep, I can feel it inside my knee, this could be a cyclops injury. This could be something called cyclops, which is an adhesion because of the surgeon, not because, or sometimes because of the physio treating the patient. He goes too harsh and too hard on him, for example, for the knee flexion, while doing the manual therapy exercises to flex his knee. So we should watch out for this. This could be a complication, and it's a lot. This needs another surgery to clear out this cyclops from the knee. Okay, so we shouldn't be too rough on the knee, but we should be enough rough to flex the knee, to extend the knee, to reach these at first, especially the knee extension. And then we can move on to better to more goals and better rehab.
Okay, that's good. That's really good to know. But is that only in like the first? When can the cyclops develop? At any point, or?
Mainly, we can see when I saw it mainly because of the surgeon. Okay, the surgeon does a lot of bruising to the bones, does a lot of cutting in the tissues when he's doing the surgery. He may be new to these kind of surgeries, so you see these kind of surgeons sometimes. If they do a lot of damage in the knee while trying to repair the knee, you can see the cyclops developing in the first early stages of the rehab. So you can see him. I know a lot of people who didn't know they had cyclops, who didn't even hear of the word cyclops. A lot of physios as well didn't hear of the word cyclops, didn't know about the cyclops being there.
I
So
never heard of it before.
yeah, so this could be a complication that needs another surgery to remove in order before we sometimes you can go to month 3 and your patient is having a cyclops and you don't even know it. If you don't even know about it, you're gonna have your patient go to the doctor, do an MRI, find out there's a cyclops inside his knee, and then go to another surgery, do another surgery to remove the cyclops, and then start the rehab all over again, which takes a lot of time. And you have just spent 3 months and you just threw 3 months away in the garbage. So that's why you should always ask the patient and always be there for him. Like ask him, are you good? Are you feeling anything in your knee? We shouldn't tell him about the cyclops being there. We should just ask him, are you feeling anything in your knee? Are you feeling something weird in your knee? Tell me what you're feeling. Other than that, we should always I always ask every session. I ask my patient, are you good? Are you feeling okay? Is there anything you want to tell me? Please don't hide anything from me. If you feel anything, just tell me. So this way I am always communicating with my patient. I'm always in the know about what he's feeling, about what he's feeling mentally or physically.
Totally. I think definitely after an injury and operation like this, you have to be working really close to your patient. And like I said, it's a patient for a long period of time.
Yeah,
So you definitely do have to be quite personal with them. And a big factor, what you said, which I really liked, was the mental aspect of, trying to talk to them in a way that it doesn't scare them or frighten them, but it more of like empowers them to get better and
exactly.
allowing them to know that you're by their side. So if anything happens, you've got it covered.
Exactly. It's better to prepare him to what he's gonna face than to make him face it alone without preparation.
Totally. No, that was fantastic. That was really good, bro. I'm really grateful for that. That was wicked, man.
Thank you. Thank you.
Albie, any feedback on it?
Yeah, no, that was a good CPD.
I just,
It's on record as well. Yeah, are we gonna have access to the CPD or no?
yeah. What I'm
Yeah,
gonna do,
yeah.
I'm gonna Keenan's recording, and then what I'll do is I'll give him access to the Google site. He can actually upload it all to the Google site for himself, and then it'll be access to all of us on our own website.
Yeah, that's cool. That was really good. Thank you for your time, man.
You're welcome, guys. Thank you.
When is the next one?
Whenever you want.